Hey, it's Justin Harvey. Thanks for tuning in to the Anesthesia and Pain Management Success podcast. With APM Success, we take a close look at important topics pertaining to business, practice management, personal finance, and careers for anesthesiologists and pain management physicians. We work hard to take your critical questions straight to the experts. Thanks for listening. Hello and welcome to episode 230 of APM Success. Very pleased to be joined by a special guest to whom I was recently introduced, Jack Dillon. Jack is the Chief Executive Officer at Anesthesia Practice Consultants in Michigan and also the Executive Director of the Association for Independent Medicine, which is not going to surprise our listeners. I'm excited to hear about that in our conversation today. Jack, welcome to the show.
Hey, Justin, thanks for having me. I really appreciate it.
So we were discussing before we hit record. I would love to hear what is a day in the life of a chief executive officer of an anesthesia group or a practice consultancy. What does that look like for you?
Sure. No, absolutely. Our name might fool, Anesthesia Practice Consultants. A lot of people assume that we do consulting, but we're actually a large independent physician-owned and operated anesthesia practice in Grand Rapids, Michigan. We cover a lot of the area in West Michigan. About 27 different buildings, 140, 150 anesthetizing locations every day, do about 160,000 cases every year. So a large independent anesthesia group. To say we're fiercely independent would be an understatement. We really enjoy being independent. We have really done well being independent, and we get a lot of attraction, candidates and the like to come to our group because we are independent and what we built here. So we're quite proud of our practice and all that we do. My day, right? CEO, right? It's sounds very business oriented, but it's a little bit of everything, right? It's a little bit of obviously the communication piece for I think any leader is the biggest part of your day, working with your various teams, whether it be scheduling, whether it be billing and coding, whether it be your human resources or finance teams, on whatever the day may take you, different objectives that you need to get accomplished, right? That's the stuff that makes sense. You're aligning with those teams, and of course, right, working with our physician leadership on things that are happening throughout the practice, problems we need to solve, which is a nice way of saying putting out as many fires as we possibly can to just get to the fires for the next day, right? But a lot of my job focus is around our operations and how we run in this ever evolving and ever more difficult healthcare landscape, right? I don't think anybody would disagree that it's probably more difficult now than it's ever been, and no one sees that turning around. So a lot of my focus is how can we do things better? How can we become more efficient, which is a nice buzzword there, but really looking at the work that we're doing, how we're doing it, and partnering with every place that we provide anesthesia care to make sure that we're doing all we can for our patients in our community. And that's probably the biggest, most important, and honestly, what I enjoy the most out of this job is really digging in deep and finding the areas that we can make this thing really run, and of course keep ourselves independent. So
you mentioned the ASA Advanced Conference, so that's like the practice management and like overarching specialty strategic thinking meeting of the minds.
Yeah.
I'm curious because I wasn't there. What are the smart people who are looking out on the horizon talking about at the Advanced Conference? Were there any themes that kind of rose to the fore?
Yeah. I mean, staffing is going to be the biggest one. I think it's felt like the biggest one last year as well, and I'm sure it's felt like the biggest one for quite some time, right? The work has grown. People are doing more and providing more care than whether it's offsites, whether it's more services, more rooms, whatever that might be. So staffing becomes the biggest theme. Is what are retention strategies? What are people doing to attract people to their practice? What are innovative ways to staff and schedule that really make it better for your team? And so I can say categorically that there's always a lot of good ideas, but no silver bullet, right? I think the answer and the theme out when it comes to staffing, especially for whether you're an independent practice, an academic medical center, anywhere is it's just going to take a lot of really hard work and a lot of strategic thinking about whether it be program growth, whether it be training programs, all of those things are the only answer to get us to a better state when it comes to, making sure that we can provide coverage. Second to that, it's probably a little bit of proximity bias, but independent practice was a big one for me. Of course, you get drawn into that conversation a lot, both in being an independent practice as well as helping be a part of a large national now effort for independent practice. So a lot of connectivity there, a lot of stories there. We're hearing a lot nationally about this is what's happening over in this area. This is what happened at this hospital, and it's become quite a theme. And then, of course, all the other great topics. I think the conference is incredibly valuable for, thought, think tank style, right? Everybody that goes, I think, finds it pretty invigorating to kind of move your mind a little bit from what you've been doing the other 360 days of the year, to kind of push you and say, hey, whether it be financial or HR or how to deal with difficult people, you get all those themes as well out of the conference.
It's interesting to me, the sort of the independent practice silo, or whatever you want to call that group of people, like in the corner of the the conference center.
Yeah.
I've always had this thought, like if you ever get an email from like the ASA and you scroll down to the bottom where it says thanks to our sponsors, and you just look at the logos there, none of those are like they're what we would traditionally call independent practices. And I'm curious, like, what is the sort of the dynamic of that conversation? Obviously, healthcare is complicated, and it's political even, and specialties are political, and who are like, what is the sort of the nature of that dialogue at a place like Advance?
Yeah, sure. So I think it's you kind of nailed it, right? I mean, it's all different walks of life and people trying to learn and understand how different people are working, whether they're part of a large national, whether they're an independent practice, whether they're part of an academic medical center. You're learning all of these things. And so the dynamic becomes very much that. As you can imagine, it can get tense sometimes, a lot of emotion, right? Behind some of those topics. Certainly encountered that at the conference a little bit. But at the same time, I think everybody's there to really listen and learn and kind of understand and decide kind of what are good situations and where have things worked out really well versus where situations that, haven't worked out so very well, and what are the lessons there. So it's a lot of dynamic, right? It's you mentioned it. There's a lot of names out there, large national groups. You don't see, even though we're a big practice, our name isn't necessarily out there as much, right? And I think conversations about whether that's a good thing or a bad thing, and because I think for years there was this perception that independent practice was quote unquote dying off, right? And while I don't think any data yet to support this, the feeling is that there's a rejuvenance or a push back towards that model of practice.
And it is geographically asymmetrical in terms of which markets are seeing consolidation, and where some places there's only one game in town or two, where others are much more egalitarian in terms of the different practice models and the representation there amongst physicians. So many. I'm excited to talk to you, Jack, because I feel like there's so many different things we could talk about, and I want to use this time the best we possibly can.
Sure.
So tell me about the Association for Independent Medicine and sort of the genesis of that, and what is it now, and what are you sort of offering to associated groups?
Yeah. No, thanks. Yes. So about a year and a half ago, we were actually at the Advance conference, maybe 2 years ago. I guess we would have been at the Advance conference. And then about a year and a half ago, we founded the Association for Independent Medicine. And it bore out of a lot of the themes that we're seeing nationally. We're seeing, that consolidation. We're seeing people being displaced because of, corporate practice in medicine, and that really impacting areas and people in hospitals. And there's a lot of stories that I'm sure we can jump into. And so our group, along with a group out of Chicago, a group out of the east side of the state near Detroit, Michigan, a group out of Wichita, Kansas, and then a group out of Oregon. Let me make sure I'm getting everybody because I don't want to miss anybody, right? And then let's see, Chicago. Yeah, as well as a few other groups and independent, even independent physicians decided to co-found the Association for Independent Medicine, and really what we're focused on is both the advocacy side of things, right? Showing, hey, where consolidation happens and makes sense, or employment happens and makes sense, like fine, right? But there are when it's the corporate practice of medicine gone haywire, it usually doesn't end up being a very good result. One of our groups experienced exactly that, and that hospital is now short-staffed, has been short-staffed for now over 2 years now, right? And it didn't work out the way that I think anybody really wanted it to, and so we're really looking to connect with other practices and tell this story and enable practices to have a bench to go to say, hey, there's a reason why an association like this forms when the corporate practice of medicine takes things to a negative place. The other side of our association is really focused on the practice management side of things, what you could call the things that somebody like myself would do day in, day out, which is, the practice management piece and the governance piece of, the best way to ensure you're going to stay in independent practice is by running a solid practice, right? And ensuring that you have longevity and sustainability. And so whether it's, like I said, group governance and how your group is running, how you partner with the locations that you serve, how you recruit and retain your people, like all of those themes and things are places that all of our groups can learn, right? I might be the executive director, but that doesn't necessarily mean that I then have all the answers for people to come to. What the association has become is a group of groups that can then share and benchmark and figure out what's working, what's not working, right? A good example of that is discussion on number of physician board members or management committee members, right? Our group has 12, right? Some groups have 3. Other groups have 5, some have 7. Usually it's an odd number. We have an even number, but that's usually how groups, well, we could talk hours as a group on what's effective. And again, it kind of depends on how your group is structured and the culture of your group. And so partnering with groups and bringing in new groups to, talk about those things to ensure stability and independence is what we're all about.
When groups reach out to you, either just because they're interested or for prospective membership, what are they looking for? Do they have like a pain point that they're usually trying to address that tends to be consistent, or is it kind of all over the map?
Yeah. I would say the main point is that corporate practice of medicine or down the line of, we're going into our contract negotiation. What are all the things that we need to know? Right. And what's a good contract? What's not such a good contract? How did you structure your contract? So contract and corporate practice of medicine are definitely the top themes, but it is after that kind of a smattering of, how do you guys manage your data? What EMR do you use? I would say the second biggest theme is what partners, vendors, services that you need to run your practice do you trust? Right. We had a bad time with this billing company or this, benefit platform or this scheduling software. What worked for you guys, right? Like, and how did you use it? And that I think has become incredibly important and powerful because what works for us might not work for others, but what we're finding more often than not is that, even though it's 6 groups with a few others ancillary involved, you're finding a lot of the same pain stories. And I think it's helping streamline, hey, these are the services that will really help support your practice, and that we've had good experience there. So, yeah.
What is the state of the corporate practice of medicine? Maybe just take a minute and define what that is. And then how is it, like, are there any markets where it's particularly problematic or particularly insulated from its ill effects? And how do you interact with that?
Yeah, great question. So corporate practice of medicine, right? I don't know that there's a dictionary definition, but you kind of know it when you see it, and it's usually when financial motivations become higher than taking care of the community, right? And while there's certainly large groups that can support an area and it works out really well, when the number one motivator is financial, it ends up not being a good story. And so you're starting to hear a lot of stories. Oregon is right now, I think, top of the news and everything that's happening there, right?
Yeah.
We're watching that even from Michigan, right? We're seeing it. One of our association members is in the Oregon market as well. I'll tell you just as kind of an anecdote, right? When that news broke, it took about 2-3 weeks before one of the leaders of one of our hospitals sent it to me over text message and said, "Hey, did you see this? This sounds terrible. Could this happen here?" Right? And my response, because I have a good relationship with this person, was, "Well, as long as you and I get along, we'll be just fine, right?" But it creates a lot of like turmoil of, is this something that can happen? Texas has also been of question in what's happening there, but I don't know that there's really a single state or area where you can say it's happening just here. I think it's happening nationally, in different markets where, but I think where it starts is where that market had a need, that hospital had a need, that group had a need, whatever it was, and then the story has kind of evolved from there. I think the Oregon story is one that I think, like I said, everybody is watching, everybody's hearing about. It's and I think it's really going to tell the story quite a bit of exactly what happens when corporate practice of medicine doesn't impacts a hospital, impacts a community.
Are there any other markets in the last, if you think back to the last 3 or 4 years, where you can maybe tell us a story of like
Mm-hmm.
what unfolded in that market with the groups that were involved and how corporate practice of
Yeah.
medicine was expressed in terms of like boots on the ground experience?
Yeah. I think commonly, right, happened in Illinois. I know it's happened in the South quite a bit, Florida markets as well. I think what the story that we hear is large national or corporate practice comes in, works with the hospital leadership for a variety of reasons. Sometimes it's aligned because they might have, similar ownership or aligned ownership structure in some sort of way, right? It's always the story that's a little bit deeper. But in most cases, right, you watch the clinical team, the physicians, and in our case in anesthesia, right, nurse anesthetists and anesthesiology assistants kind of pull out of that space, right, and then so that hospital is now left without staff, and so the large national corporate group brings in locums, right, and it never adds up to be enough. Usually, you can get a bolus of people in the beginning, but the way those deals are often, structured is it doesn't make a lot of long-term sense to keep people there, or that large group that is now, contracted with the hospital has to go back to the hospital and ask for more, usually money, or they offer their services to make them quote unquote more efficient, which means we just have to, consolidate your rooms and limit your staffing, right? And so those are stories. Again, whenever you read them, those are the ones I hear about. Those are the groups that when they come to the Association for Independent Medicine and they reach out to us, those are things that we hear. And again, I always agree with the statement that every story is a little bit different, right? We can share these stories, but whether it was this weekend at Advance, whether it was, a call that we have with a new group, you tend to smile and nod because it's a story that you either have lived through or one of the other partner groups in the association or one that we know of has also lived through.
Yeah, it makes sense. Um, Tell me, in terms of the way that this is evolving and the way it's impacting your practice, is there anything that you're worried about today, this year, that maybe a year or two or three ago was not on the radar, but it's sort of manifested itself recently?
Yeah, I think everybody that you talk to in anesthesia, especially, is going to say staffing and recruitment, right? But I'll add another leg to that staffing and recruitment issue, which is new entrants into the market of surgical center space, right? So hear a lot of these large national groups that are interested in starting a line of surgical centers, right? I won't name names, but there's a lot of interest in because it makes sense. It's profitable work, right? And so my concern, right, becomes if those places start to pop up, right, like coffee shops, then we're going to be dealt with a dilemma, right? There's going to be that not only more financially and commercial, right, payer work that's outside the hospital, but the bigger motivator is going to be that balance, right? So surgical centers don't have a call team, right? And so as that work gets pulled out, and some of these large organizations have the dollars to pay, right, nursing staff, anesthesia staff, tech staff, to ensure that they have their team. What does that look like for hospitals? So this if we don't solve the burnout and the autonomy in terms of individual schedule autonomy problems soon, those entrants into the market are, I think, going to create even another layer of complexity, as well as for if I'm honest, right, I want to support our community. I have great relationships with all of our hospital partners, but I also have a practice to run, right? And it's somewhere between, hey, if there's work out there that you can continue to sustain your practice long term, that might be something that you have to consider while your staffing is still stretched, right? And so what does that mean long term? So I think that really is something going forward that's going to be an issue. And of course, there are states that have certificate of need requirements. Michigan happens to be one of them, but I mean, there aren't many certificate of need states left, right? So you have to wonder in those spaces, there could be exponential growth in the surgical center space.
Yeah. The counter argument to that would be, is it bad? Will not the invisible hand of the free market reach an equilibrium at some point? Or are we just going to have a bunch of empty ASCs that we built and financed and now sit vacant? How would you react to somebody who's like, well, maybe, CON feels like it's like the mafia trying to keep out people who are just trying to open a small business and meet a met need?
I don't disagree. I don't disagree. I can't. And I'm our group's resident MBA, and so those business concepts I certainly agree with. Let the market bear what the market's going to bear, so to speak. But at the end of the day, it creates quite a day-to-day operational nightmare and a strategic one. Luckily, in my market, I can tell you that we have the relationships with the places that we go, the hospitals that we can have this open dialogue. But I don't think that's the case for everybody, right? And so that becomes, and even outside of just being an independent group, I would take it a step further, right? If you're employed by a hospital and suddenly a surgical center opens up across the street and they're offering you Monday through Friday, end of days between 4 o'clock and 5 o'clock, and it's similar compensation to what you're at the hospital. I mean, who wouldn't take that, right? I heard more than once this past weekend that I don't want to spend another day in the hospital, right? I hear that from people coming directly out of training or who've only been practicing for a couple of months. What can I do to get out of the hospital, right? And so I don't envision that concept slowing down at any point in time. So to answer your question, it becomes, while I agree, and we'll see where that goes, I also, it's going to be, people like us that are going to try to solve that problem.
I'm sure you feel the same tension that I do. I, as an advocate for individual physician families and practice owners and such, it's like, well, I solved the micro problem. The macro problem, it's a big problem that's too big for me to solve. But at the same time, you have to acknowledge the inherent, the cognitive dissonance or whatever you want to call it. Like, I don't want doctors to be burned out, pissed off, quit early, hang up their medical degree because they can't take it anymore. But I also want to be able to get a surgery when I need one, or have aging parents or other family members be able to access care. So it's, it's the 17 different ways that things need to change.
It is. Yeah. Yeah. On that macro level, right? Like just kind of going down that line, you know, it also, one of the themes that I see, again, no data to support it, but I hear this quite a bit, is that, you know, when there's a perceived quote unquote good situation in one practice or healthcare system, people will get up and leave to go there, right? And that good situation then becomes compounding, right? If I'm short staffed 5 people and the practice across the state is short staffed 10, and that practice says, well, they're only short staffed 5, and if I go over there, they're only short staffed 4. Well, now you know what I mean? Like that,
Zero
I
sum.
think is, yes, it really is.
Mm-hmm.
And I think it's happening more than we really acknowledge, right? And so, you know, that's why I think a lot of the theme is, hey, what can you do to recruit and retain? And like you said, not burn our physicians out.
I can tell you, I have 100% observed that phenomenon with clients of mine who are in a bad practice and their friends are leaving, and they're like, "Why the heck should I be the one to go down with the ship?" And who could
Yeah.
blame someone in that circumstance? That's just
Yeah.
you doing what you need to do to, pay your own bills. I want to ask
Yes.
a very basic question that I feel like I probably have known the answer to in the past, but in terms of billing and billing for anesthesia services, providing anesthesia at the hospital versus doing it at a surgery center. I understand like payer mix or the
Mhm.
difference between payers in terms of compensation, but is there a site of service differential that would apply if you're doing a surgical procedure at a hospital with anesthesia versus in a surgery center?
From an anesthesia collection standpoint, no. I mean,
Okay.
you're just going to benefit from usually more commercial payers. And then the second benefit is, you know, that it's true everywhere. Surgical centers tend to run leaner and a little bit more efficient than the hospital. Hospitals are big buildings, right? That are going to have a lot more operate. So that does then translate into cost, right? And
Mm-hmm.
so and even the hospital, right? Any hospital you go to, I would certainly say that, you know, the hospital and surgical centers are going to find that they're more efficient there than they are at the hospital. But no, not from a not from a site of service standpoint. We get paid the same.
You mentioned something earlier that I want to circle back to in terms of the
Sure.
outlook for independent practice, because I'm glad that you're optimistic. And it's, obviously, I think you got to sort of break this down by specialty, because for some of them, I don't see any
Yeah.
path out of the woods for independent to come back, but it's not the same for every specialty. So tell me about what you're seeing in your, in anesthesia, and what it is that makes you optimistic that some sort of swinging of the pendulum may bring things back towards
Yeah.
independent land?
Yeah. No, great question. I am optimistic, not just because of the roles that I'm in, but I think there's a lot of demand for it. I think a lot of the theme for a number of years was, I'll take the hospital employed job, or I'll take the large group job because, you know, that's stable. And I think that can very well be true in great markets. I think speaking, you know, specifically in anesthesia, again, I think what we're seeing, right, is more people driving towards more autonomy in their life, that life work or work life balance, whichever one you prioritize first, right? And so you're seeing people become locums, right? And you know, I can say anecdotally, right, you'd get some locum agencies that would send you a stack of resumes, and you know, not to sound critical, but some of those people were locum for a reason, and you'd say, oh, I don't know, we probably can't go with this individual. Now you're seeing a lot of people who are doing it to gain that autonomy and gain
Mm-hmm.
that balance, who want to work specifically. And so I think the combination of that, and the combination of technology being our friend, frankly, of being able to run a business leaner and faster with all the tools that we have, there's a lot of push for people to go independent again and work the way that they want to work. And I think out of that will bore, and I've seen it happen in a few spots. You have a couple of, you know, people that pull out, become whatever, and then they start forming their own entities, right? And so I think that we're going to just see more of that, especially as I mentioned, that the surgical center and the independent surgical center space grows as well. I think that's the direction I see going. not fully in anesthesia, but I think we're going to see those themes.
I have observed the same phenomenon, and I'm going to continue to work to figure out why I've seen these, like either a whole hospital or a whole site of service that's like a branch of a bigger anesthesia group where there's like this opportunity for independence that happens, and there's all of a sudden local autonomy exists, and whether it's like an independent company that's formed or contracting collectively with the hospital as part of some sort of transition. My sense is that this is happening more with anesthesia, and maybe it's because that's just the water I'm swimming around in, but it seems like it's happening more with anesthesia than other specialties. I wonder if that's true, and I wonder if there's like economic drivers there in terms of how the reimbursement works, or the fact that it's already sort of untethered from like the compensation because the RVU keeps getting slashed and slashed and slashed. Hospitals, like if you need anesthesia, you got to pay more than what Medicare is going to pay anyway. So because of that decoupling, it's already a little bit more sort of free market-esque in terms of the price setting. Have you observed that, and do you have any insight there?
Yeah, I would agree with exactly what you said and the way you said it. I think there's a lot of that theme happening. I think as everything across healthcare has become immediately more expensive the last couple of years, salaries have risen, for staff and things are, hospitals are really, just having to pay more for the same work. Where are you going to lean? Well, you're going to lean in the place that 65 to 70% of your revenue comes from, and that's your operating rooms, right? And so I think you're right. While it's happening in other specialties, you're really seeing it in anesthesia because people want that, right? That service, and they want as much of it as possible to capture as much of that volume as possible. I said this weekend, our group feels very much like partners with the places that we cover, and we can work together to align schedules, and it feels very good. And I don't want to paint it as sunshine and rainbows because it's also hard work, but we have that going for us. Whereas other people in other markets feel very much like their anesthesia practice or their service is just a light switch. I'm here when you need me. Not here when you don't need me. And that arrangement might be very beneficial, but I think we're, to keep going with that theme, you're seeing that light switch stay on a lot longer than it used to. And you'll, in places, hospitals across the country will take as much of it as possible.
I want to cover one last topic in the time we have left here. I'm curious how the No Surprises Act and the way that it's evolved in the last couple of years in terms of how we understand the arbitration process and all that. If you have any thoughts on like the impact that you've observed, how that's impacted any of your member practices with AIM, and any other thoughts you have about how you think it may develop and impact the specialty going forward.
I think when it all started to come out, everybody was very concerned, right? And I still think that there is reason to be concerned. Our practice hasn't admittedly had to deal with it quite a bit, and I was involved up front before our state legislation went through with our state society and a few other entities in the state to try to say, hey, give us the information that makes sense. How does this process actually work? So I can speak to it, from our practice, like what actually occurs. I can say in the few things that have been arbitrated, gone to independent IDR or independent dispute resolution, it's worked out. All right. And so I think what I would describe it as is the process is ill-defined, but my experience has been that it's okay. That said, I've heard of cases, especially I think there was one out of maybe Tennessee that was that took 18 months to arbitrate, and I don't know if exactly that state, but there are pretty bad cases of arbitration taking too long or not being a reasonable representation of the work that was done. And so I've wondered if this will just take time and evolution to get to a place where it's a little bit more manageable and we understand kind of those guardrails a little bit better. That's my hope. I think everybody agrees, right? No one wants a patient to get stuck with a surprise bill and one that they can't afford. And again, a practice like ours, we work with patients and we figure out, how no one ever gets sent to collections by our group, right? And so we work with patients. I don't know if also that's the case. And when you look at corporate practice of medicine, right, because I know that there's some fallout there as well. But when it comes back to that, I can say conversations between practices and payers just need to be positive, right, and representative of the work that was done, and then hopefully the resolution will work itself out. So much more to see on that front, Justin, for sure.
It seems like the groups that have been pretty, practicing what I would call like an ethical business practice in the past as it relates to billing. They haven't been like really zapped in this department.
Right.
They're like, holy cow, like 40% of our revenue dried up because we were just balance billing people $13,000 for that procedure. And they didn't realize, like, practices that were being normal and equitable, I think, have not suffered. But I think, and what I'm hearing you say as it relates to the independent dispute resolution process, I think one of the places that even practices that acted equitably have been hit, it has been the more they've been pushed into the IDR. I think there was like a higher cost to adjudicate each case that I don't understand like the state courts and how it impacts national policy, but I know in Texas it was the per case adjudication price was significantly lowered. But even so, because historically and this was another thing that was challenged in Texas, the median in-network rate for the different payers was a factor that was heavily weighted to determine what is the fair price for the procedure, was incentivizing commercial payers to push out all of the, to push people out of their networks who had a higher negotiated per unit rate to lower their median in network rate to then be able to push lower prices all the way down to the physicians who were trying to have their cases adjudicated. So have you interacted with that at all or experienced any ill effects with your practice or heard any stories about how that might work?
No, and thankfully I haven't, to be honest. That does sound like an administrative nightmare, frankly, to get to a place that you should get to anyway. And frankly, in those cases, we have to ask ourselves, what's the actual savings there, or whether it's time, effort, or money, right? Like, that's a lot of work to get to a 1% difference in what was originally going to be paid to what was actually paid, right? Like, and so I can see how those things can happen, but thankfully I haven't had to personally deal with that, and I don't know any of our member groups that have either. So hopefully that is a good sign for groups that are operating fairly within the market, aren't going to experience those types of things.
Cool. Well, we'll wrap it there, but Jack, I can tell we should have another on the record conversation in the not too distant future. Jack Dillon, CEO of Anesthesia Practice Consultants and the Executive Director for the Association of Independent Medicine. Thanks for joining us today on APM Success.
Hey, thanks, Justin. Take care.
If you liked what you heard this week, head on over to apmsuccess.com, where you can find more content and free resources to help you build a successful career in anesthesia and pain management. If you wanted to leave a review in iTunes, I'd also really appreciate it. Thanks for using some of your valuable time to join me today on APM Success.